Pettus, and most of our team members are just back from the World Palliative Hospice and Palliative Care Day celebration. So wishes to you all, and hoping to celebrate it sometime together in the coming years. So as Rajlakshmi mentioned, today we are having a very important session on opioid availability. We'll be, most of you might have gone through the opioid availability sessions during the foundation course, but this time we are going a little bit in detail about the opioid availability across the world and experience from across the several countries. So today we have three faculty, Katherine Pettus. She is a Senior Advocacy and Partnerships Director for IHPC, working for a vision of a world free from health-related suffering. And she represents IHPC at meetings of UN and to ensure the inclusion of language relating to palliative care. And she also mentors IHPC members to foster governmental and non-governmental partnerships in their own countries, so that there is an effective service delivery for people with palliative care needs. She holds a doctorate in political theory and a master's degree in health law and policy. Thank you so much, Katherine, for agreeing to be a part of this session. Next, we have Smriti. Smriti heads the strategic programs and partnerships of Pallium India, and she works mostly to ensure safe access to opioid analgesics for pain relief in India by engaging central government and other key stakeholders. And she also collaborates, she is a key person for the WHO Collaborating Center for Policy and Access to Pain Relief with WHO CRO for essential drugs and medicines. And we have, both of them have a long list of their accomplishments and the roles that they play in this field. But I'm just focusing on the most important ones. Thank you, Smriti, for being with us today evening. And yes, we have Dr. Rajgopal also joining us for the session. I don't think he'll need a long introduction because all of you are familiar with him. We have heard from him from foundation courses or many other programs that you have attended with us. So Dr. Raj will also be giving his insights into this topic. Thank you, all three of you, for agreeing to be part of this program this evening. Over to you. Yes, Dr. Rajgopal specifically mentioned he's not a faculty member. He's a silent listener, a fly on the wall. So he'll talk only if both of them demands him to unmute.
Thank you, Shri, so much. And it's really great to be here. And like Raju said, a very happy World Hospice and Palliative Care Day to all of you. I'm going to ask Katherine to start us off, and then I will come in with the Indian context of what we're here to discuss today. Katherine, over to you. Floor is yours.
Thank you, and World Hospice and Palliative Care Day, happy to all of you. It's going to take me a minute to share my slides. Do I have permission to do that? Yep. So just give me 1 second and I will do it so that I can also see my notes. Now, why isn't that coming up? I don't know why that. So thank you all for being here and taking the time to listen to this brief lecture. Does anyone know how I can get rid of the gallery? I have to go to view, right?
Just go to the view. It's not the view, this the single icon there. Just click on that on the right.
The 3 dots?
3 dots, yes.
And then I go to hide video panel. That's what I want to do. Okay, here we go. So thank you for being here and taking the time to listen to this brief lecture on the issue of access to essential medicines. And first of all, thanks to Pallium India, to Smriti and Dr. Raj for inviting me. We've been partners in this enterprise for a few years now. So I'm Katherine Pettus, as I was introduced. I'm the Senior Advocacy and Partnerships Director for the IHPC. We're a global membership organization whose vision is a world free from health-related suffering. And I invite you to become members, if you're not already, and take advantage of the many educational and advocacy benefits that we have to offer. Most of my advocacy work is at the international level, at the United Nations organizations, to raise awareness about the need to improve availability of controlled medicines for the relief of serious health-related suffering. Because as many of you know, and I'll explain a bit in this presentation, the United Nations organizations actually supervises access to this. So we have had some luck in improving access, but it's slower than we'd like because the main implementers are governments. So the main blanket of norms and laws and conventions is at the international level, but member states like India have to implement what we get recommended at the international level. So this is going to be a whirlwind tour of what's a very complex topic with deep historical roots, entrenched cultural narratives, and ethical importance for all medical practitioners. And if you want to delve more deeply into the topic, if that kind of complexity interests you, I suggest that you take my advocacy course. It's an e-learning course, which is available on our website, and read some of the references that are linked at the end. But for today, we're just going to learn a few things. We'll learn the historical timeline and about scheduling, which I'll explain. Internationally controlled essential medicines, what that means. Opioid phobia, what that concept means. The barriers in access to medicine, really generally, and then what's called the principle of balance. I'm also going to talk about what equity is and what that means, and what inequity is and how that can be remedied. So let's see, next slide. So as many of you learned in school, I didn't, but now I do, the global trade in opium, which was mostly under the British Empire in the 17th, 18th, 19th, and early 20th centuries, used to be legal. And it was the coin of the realm of the British Empire, which cultivated and processed opium in India, sold it to China, and brought the profits home to London. And more than 2 wars were fought to protect this trade. Economic historians call the opium trade, call opium and the British Empire, economic historians call the British Empire the first drug cartel. And actually it was a legal drug cartel, unlike the cartels now. So before opium was commodified by the British Empire, and its production was industrialized, it was, and still is in many parts of the world, a traditional medicine. It's not what's now called a narcotic drug. And the prohibition movement that gave it that name and worked hard to ban the trade was driven by social reformers and missionaries from the UK and the United States, who saw it as corrupting the populations, mainly in China. Their goal was to prohibit all cultivation, manufacture, and pharmaceutical distribution that was illicit or illegal, and regulate global cultivation only for medical and scientific use. And the result was a complex international control system that did not mandate governments to make these medicines available. It only mandated reporting of quantities, but it didn't mandate governments to make them available and tell them how to do it. But it did mandate control And it told people how to punish and to do the kinds of controls that we still think of as the war on drugs. So this kind of prohibition system that was institutionalized, and that's the middle panel here in the drug control schedules and treaties, that kind of control system made it very difficult for countries, usually former colonies, with weak health systems, to develop the kind of administrative systems and supply chains that allowed for availability. They just didn't have the institutional capacity to comply with any kind of availability for medical purposes while preventing diversion and abuse, which is the legal language of the treaties. So they got plenty of help from the international community to prevent diversion and abuse, lots of money for armies and drug control, but they didn't get and still don't get much help to make medicines available. So only in the last 2 decades, that's the final box on the right, since the development of palliative medicine and addiction medicine, has there even been an awareness about the global crisis of unrelieved pain, the lack of access to medicines in 80% of the world, and what's called quantification of serious health-related suffering. Suffering wasn't even quantified till 2018, when the Lancet report with those calculations were published. So we've got 2 decades of advocacy, essentially, in the 21st century against 1.5 centuries of control. And that's the backdrop for our advocacy, which it's still slower than we'd like, as I said, but it's happening. And we're in a new epoch, really, where science and the development of science, medical practice, like all of you, and spirituality are basically shedding light on those old laws and norms and slowly changing the paradigm. So you today are part of that paradigm shift, and thank you for being here to do that. So there are 2 parts to internationally controlled essential medicines, which is the category of most medicines used in palliative care. The first part is internationally controlled, and the Single Convention on Narcotic Drugs, which we saw in that center panel on the previous slide, codified all the earlier opium control treaties that were made among what were called the Great Powers, and that were approved by all member states in this single convention, most of whom were decolonized by then in 1961. So all substances under this convention containing narcotics, as they were called then, even if it was cocaine, which is not a narcotic, were included in schedules. That's what they were called, lists, which were appended to the convention. That's why they're called schedules, and the process where they're put in the list and ranked according to their perceived therapeutic use and harmfulness to society, on the other hand, are put in schedules with different levels of control. But remember that there was no such thing in 1962 as palliative and addiction medicine, and there was no evidence base for therapeutic use or harm. But those schedules are still the rule internationally, where all those medicines are. So there was just at that time the perceived evil of addiction, and that was the word that was used in the treaties then, which had to be eliminated. So there was no evidence base, there was just this moral panic around addiction. So the second part of internationally controlled essential medicines is the words essential medicines, obviously. And according to WHO, those must be available in health systems at all times in the right formularies for public health benefit. So on the one hand, the medicines we use in palliative care were internationally controlled, are internationally controlled. And on the other hand, they're now on the WHO model list, with the list of palliative care medicines being added in 2017. So under one branch of international law, they're strictly controlled because they could be harmful. And on the other, they have to be essential under public health law, and they should be available all the time. So overcoming this institutional tension, that's what it's called, requires good clinical training, which you're doing, obviously. It requires administrative training, regulatory science, and robust supply chains to ensure adequate access without diversion and misuse. Diversion and misuse just deepen what's called opiophobia and contribute further to lack of access for medical purposes. So opioid phobia, which results from this cumulative effect that I've been talking about since the rise of the opium trade, is literally fear of opioids. And phobia just means fear from the Latin. Health system weakness, which is prevalent in most lower and middle income countries, plus lack of training and the entrenched international narcotics control system produces opioid phobia, even for rational use to alleviate severe pain. But opioid phobia, and this is the good news, can be reduced with correct training and good regulations. Those are regulations which are not overly restrictive. Such regulations should prevent diversion and misuse and allow educators to promote the clear examples of how patients and families can benefit from appropriate and rational use. The drug control treaties we talked about earlier institutionalized opioid phobia, as I said, when they called addiction an evil that had to be eliminated. Because now we know, they didn't know that at the time though, that addiction is not a moral failure, but it's a form of suffering, and it's also now called a disease. I'm not sure about that, but the point is, it wasn't a moral failing. And they thought then that it could only be curbed through supply control and punishment. We now know the most effective approach to addiction is good evidence-based treatment. So although strong social stigma surrounds the use of opioid medications, this barrier can be overcome with appropriate clinical training, a balanced regulatory framework, and public education. The strong stigma in many countries produces the inequity that we see in this slide. Inequity just means injustice or unfairness, and global inequity is unfairness between countries. It means that people in some countries and regions get what they need, while others don't. It's different from equality, which means everyone gets the same. The bar chart on the left, which shows the amount of opioids under international control available for medical consumption in subregions, shows South Asia sixth from the right, excuse me, which means you can hardly see it compared to North America all the way on the left. And the map of distributed opioid medication equivalent, which is the map, which most of you are probably familiar with from the Lancet Commission. It shows the fat countries, the overblown, distorted countries where there's an excess of opioids. And for instance, Australia, there's some issues there. And where opioids are not distributed according to suffering, distributed opioid morphine equivalent is the jargon that's used for that, are very thin and they're shrunken. And India is just a tiny twig. So you can see by that this global inequity. And I suggest if you want to learn the methodology for this map, you look at the Lancet report on pain and palliative care, which is linked in the references. But excuse me, global inequity in access to internationally controlled essential medicines is a form of injustice. It's global health injustice, which many of us are working to remedy. This is a different way of imagining inequity in access to opioid medications. I don't know if you can see, this is inequity in morphine access. So this pie chart on the left is from the 2020 International Narcotics Control Board report and shows that other countries, which is 80% of the world, is in black in this part. And that represents 80% of the world's population that consumes only 13% of the global supply of morphine, with the US in the yellow part and Europe in the green. Most of the available morphine in the world, according to the INCB, is not utilized by pharmaceutical companies to prepare morphine preparations for palliative care, which has a negative effect on the capacity of health services in lower and middle income countries to treat pain, because it's being made into codeine instead. And on the right, what we see is, this is some new research, so it's unpublished data, and we ask you not to take screenshots and reproduce it. But these are distributed opioids by country income level. So we have the fentanyl in red, oxycodone in gold, and morphine in green. And you can see the lower and middle income countries here on the left, which is almost a flat line again compared to the high income countries. And it's blown up just so you can see the distributed opioids and the disturbing trend towards the use of fentanyl and oxycodone, which are the expensive non-generic pharmaceuticals rather than oral morphine, which is cheaper. And obviously it's generic and it's less expensive to produce. So what this graph shows is the influence really of the pharmaceutical industries on health systems and the lack of putting patients and families at the center of health policy. So another barrier is lack of training. The International Narcotics Control Board, again, is very concerned about the global inequity we've just been looking at, which has been very resistant to change over the last 2 decades. So it surveys countries, the board, as it calls, surveys countries about perceived barriers, which are graphed on the left. Those are the lines on the left. And I'm sorry if it's too small for you to see, but I'll just explain. In 1995, the report showed that almost 70% of countries said that the main barrier to access to medicines, controlled medicines, was fear of addiction. So in other words, opioid phobia. And that's the purple line here that falls down sharply in 2014 and then levels out. But governments now report the primary barrier, and I'm saying now, but this is 2020 data, as lack of professional training and lack of awareness of the benefits of controlled medicine. So that's the yellow line. So that's the main barrier now, is lack of professional training. So to me, that means logically that governments need to do more to promote training and awareness to reduce that barrier. And it's a good thing Parliament is doing this. The graphic on the right, this one here, is from the American Cancer Pain Society, which it also supports the INCB survey. And it says that health professionals feel they have inadequate knowledge and lack of awareness. And the health system barriers are limited access to pain specialty care and reimbursement for opioid therapy. So they're too expensive for many people. But still, the main barrier is lack of training. So that's why it's so great that you're here today. So the cumulative effect of all the barriers I've been talking about, which is rooted in history and culture, are unbalanced regulatory systems and inequity. Governments that are fearing diversion and the evil of addiction, as they still call it, have failed to ensure availability for medical purposes in 80% of the world. So when the cart, like this cart of restrictive regulations is overloaded, it can't move forward to ensure public health. Inequity is another name for imbalance or injustice, and unbalanced regulatory systems can result in two different scenarios, both of which are unjust. When appropriate control mechanisms are not in place, the pharmaceutical industry rides roughshod over regulators and widespread non-medical use of opioids occurs. The sources may be illicitly manufactured opioids or licit manufactured opioids that are diverted for non-medical use. The North American opioid crisis is one example, but it's now being shown that fentanyl and heroin, which are illicitly trafficked, are the main causes of the overdose epidemic, not licitly produced opioids. And on the other hand, if the barriers are overly restrictive, you get unnecessary pain and suffering, which is what most of our colleagues in lower and middle income countries are confronting. The skinny countries on this same version of the Lancet map are familiar with. So we recognize that both appropriate measures to ensure the safety and access at the same time are in place. So how is balance introduced into imbalanced systems? That's the question we confront with our advocacy. And I plagiarized this slide from Dr. Raj's presentation at the recent intersessional meeting on the Commission on Narcotic Drugs, which focused on human rights and drug policy. And Dr. Raj noted the effects of an unbalanced global system, which estimates 37 million people in the world with serious health-related suffering because they don't have access to treatment. So those are people with substance use disorder on this side, and then 61 million who don't have access to internationally controlled essential medicines. This is a seriously imbalanced system that's unjust and inequitable. So it's not acceptable, which is why our policy asks are for balanced model regulations and international guidelines to ensure access as well as treatment for substance use disorder. So this is not an either or, but a both and. We can have both at the same time. It's something you can advocate for, joining with Pallium India, which is working on the regulatory framework. And more than anything, it requires appropriate training for rational use. So I'm just going to wind up here with the principle of balance. We reintroduce equity into the system by urging governments to implement the principle of balance, which is the dual obligation to prevent diversion and abuse of what they call narcotic drugs, which we call internationally controlled essential medicines, while at the same time ensuring access that's adequate for opioid analgesics for the prevention of pain and suffering. The principle of balance emphasizes correct governance and stewardship of essential palliative care medicines such as opioids. It's a matter of global health justice that internationally controlled essential medicines are equitably distributed, both within and between countries, to alleviate what in the 21st century is entirely preventable suffering. So the takeaway is that the opioid phobia in the context of weak health and regulatory systems combined with lack of training produces the inequity we've seen in the maps. And thank you for your attention. I direct you to our website, hospicecare.com, what we do, and then the advocacy program has a resource list, and that's where my advocacy course is. So thank you very much for your attention, and I will give you back the floor.
Thank you so much, Katherine. That was a perfect start to our session. And I think I'm always so enriched by attending your sessions. So I'm going to pick up where Katherine left off. And it might look like my screen is muted, but I'm logging in through Pallium India's speaker. So I'm going to pick up where Katherine left off. And I think it's really important for us to understand the entire the larger context, because all of us are intimately influenced and affected by global dynamics. So thank you, Katherine, again for sharing that. I'm going to take you to my slides now. Is that? Yeah, okay. Okay, I just want to acknowledge the fact that this, the content of this slide deck was initially created by Smriti Tandon, who is an advocate and the Deputy Director of Lawyers Collective. And Lawyers Collective has done incredible work in India to improve access to opioids. And particularly, I mean, without Lawyers Collective, our work with changing legislation would not have gone very far. I have added several slides in order to tweak the session to this audience. So let's just get started. So like what Katherine said, there is a gross inequity in the amount of morphine consumption, as well as in terms of pain relief. In the global average is 61.5 milligrams per capita. Asia is 36 times less. And I'm also going to just reiterate her slide of what are we asking for? We're asking for the principle of balance. And this is what ideally the principle of balance looks like, where we prevent diversion and illicit use while ensuring availability for medical and scientific purpose. And this is, again, just underscoring what Katherine said, that we have a dual responsibility. And when we say we, it's all of us. And of course, this is incumbent on member states and governments. But how do we get to that? All of us have to be aware of what we're fighting for, what we're advocating for, and where we need to go. And unfortunately, this is what the situation looks like. We're still coming at it largely from a point of view of control rather than ensuring access. And in India, one of the biggest barriers to access was the Narcotic Drugs and Psychotropic Substances Act that was enacted in 1985. And it had a tremendously negative effect on the availability of morphine. And the NDPS Act really was a result of the larger rhetoric of the war on drugs that had emerged in the West, in America especially, through the 60s, the 70s, and the 80s, and had this ripple effect across the world. And the interpretation of this war on drugs was very, very reductive, and it resulted in a tremendous amount of harm, especially in countries like ours, low and middle income countries. So how badly did the NDPS Act affect access to morphine? This much. And we saw a 97% drop in the consumption of morphine from 1985, when the act came in, when the consumption was reported at 716 kilograms. And by 1997, it had come down to 18 kilograms. What this also means is that the pain burden of the country has gone up proportionately. So we're not just looking at consumption, we're looking at how much pain, how much of the pain burden has increased. And I think that's the lens that we need to continue to look at this from. So this was an issue that was identified by doctors like Dr. Raj, who were frustrated at the fact that there were so many people in pain, so many who were suffering. And in spite of the availability of medicines to treat pain, the medicines were available, but they were not accessible. And that is a big difference. Something can be available, but it can become inaccessible due to various barriers. And these doctors initially also, this is how they framed it, saying pain relief is vital to palliative care. In order to provide pain relief, we need access to medicines. But then what was standing in the way of providing pain relief was the NDPS Act of 1985. And drawing this logical line was very essential because that is where the crux of the problem lay. Now, the Narcotic Drugs and Psychotropic Substances Act has been in the news a lot, and whatever you hear about it is always about punitive action, for misuse and diversion. You always hear about the control and the law enforcement side of it. So civil society advocates, physicians, they went into it knowing that it was a huge, huge, huge beast that they were taking on, but it had to be done. Now, there were several, I'm just going to briefly go through a few slides. Under the NDPS Act, there is a classification of drugs under narcotic drugs, psychotropic substances, and controlled substances. And it's all fairly, to me at least, it's still quite complex. And these are just some examples of what falls into different categories. All of these are controlled substances. I just want to be clear about that. Narcotics and psychotropic substances are also controlled substances. But in this context, we're talking about controlled substances as what goes into synthesizing other medication as well. Now, one important point to remember is that drugs are not legal or illegal per se under the NDPS. The legality depends on what is the purpose for which the drugs are being used. Is there a medical or scientific context? And the manner in which they are procured and used. And where have you got it from? Now, these are important things for us to remember. The drug itself is not legal or illegal. It is the purpose for which the drugs are used and the manner in which they're procured. Now, I'm talking about medical drugs. Now, well before the efforts to bring about change came about, there was a study that had already been done in Kerala in 2001. And this study looked at 1,723 patients. And we saw that there was an overall consumption of about 13.6 kilograms of morphine, approximately 7.9 grams per patient. Kerala had a very strong system of documenting the movement of this medication. And when they looked into whether there was a lot of misuse or diversion or any at all, they found that there were, first of all, no major unaccounted discrepancies. And when the minor discrepancies were found, they were looked into and they were examined. And what they found was that this discrepancy in documentation did not actually mean that there was misuse or diversion. And this is an important study for us to remember because this is something that predates the efforts for change. And this was a vital piece of evidence also to show that you can use opioids safely if you have certain systems in place. And that played a major role in the efforts later. Now, there were several problems with the NDPS Act. And one is that they had overlapping categories. It was very confusing. Opioids were classified under various categories, under manufactured drugs, under something else. So it wasn't very clear where exactly opioids distinctly fell. There was a division of regulatory powers. Now, this pertained to the drugs themselves, the activities, I'll talk about that, like this is about transport, possession, all of those things, and who was authorized to grant permission. And wherever you went, this division of regulatory powers made it very, very difficult to understand who you needed to go to get what permissions. Now, the rule-making powers for the manufacture of opioids lay with the central government. But the rule-making power for possession, transport, sale, use, and consumption was with state government. So every state could do what they wanted based on what at their discretion. So the regulatory powers were split. Now, the problem then with the rules, so rules are what operationalize an act. So I can have a law and an act, but it's the rules that allow me to operationalize and implement the act, right? So there were problems with the rules as well. Now, at the state, multiple activities required multiple licenses granted by multiple agencies. Every state had its own set of rules, and some of them were extremely onerous and frankly unrealistic rules. Like, for example, in Goa, a patient had to personally present the prescription to the collector before approaching a pharmacy. Imagine a person in that much pain with an advanced illness showing up at the revenue department, going to meet the collector, standing in line, getting this prescription vetted, and then going to a pharmacy. There was inconsistency between states, like I said. So in Uttar Pradesh, it was the excise department that made the rules, but in Kerala, it was the state drug controller. So if you were moving between states, the same protocols did not apply. You would have had to find out who's in charge of what here. And there were rules for import interstate and export interstate. So if you wanted to bring opioids from a state where it was manufactured into your state, you needed an import-export license, which was very, very difficult to get. And in some states, there were just no rules. So there was no access. And there were some other issues like, a quota system for international reporting requirements and things which people just didn't want to get into. So as you can see, it was a big mess. And even now, just trying to go through this, sometimes, it boggles my mind as to how people got even those 18 kilograms, how did people get it? So that's when the efforts to change came in. And what were the different dimensions in which we looked at the change needing to take place? One was in the policy itself. The other was in the law, in litigation. So one was through litigation and one was through law reform. Okay, so there was a lot of policy advocacy that went in, and the Department of Revenue was approached, and they recommended simplified model rules after being informed by certain people from civil society, from physicians and lawyers, etc. In 1998, there was a public interest litigation that was filed in the Delhi High Court and then in the Supreme Court of India in 2007. And this was filed by a caregiver of a patient, if I'm not mistaken. And law reform finally was only initiated in 2012 when we figured out that ultimately the biggest problem lay with this very draconian Narcotic Drugs and Psychotropic Substances Act. And so what were the principles guiding this law reform? First of all, there was a recognition that the medical use of opioids is not only permitted, but it is indispensable for health. So that was point number one. The second is, it is laid out in international treaties and conventions that you have to have a principle of balance, and you have to ensure medical use while preventing misuse and diversion. We had to acknowledge that while, yes, the NDPS says, yes, morphine and opioids are available, it completely frustrates the process because of all the previous reasons I just gave you about the regulatory powers being different, the states having different rules, etc. And the fact was that India was exporting morphine, while the millions in pain in India were not getting access to pain relief. And that was a very, very important point. And that was a point that was also highlighted by caregivers, by patient advocates. And then we had to show that, yes, there evidence exists that we can safely use opioids. And that evidence lay in Kerala, which was also documented in a Lancet study. So that also provided that piece of evidence that is so important in law reform. So once all of these things were clarified, there was this tremendous effort by civil society, and it was a 19-year journey. People engaged with the parliamentary standing committees, people engaged with the Department of Revenue. And just to clarify, in India, NDPS and the access to opioids comes under the Department of Revenue in the Ministry of Finance and not under Health. And this is this is sort of a residual impact of what Katherine was talking about, that opium was a trade commodity under the East India Company, and it was always under the Department of Revenue. So that didn't change. Several meetings had to be had with different people, submissions had to be made. And that's where Tripti Tandon and the Lawyers Collective were really, really helpful, especially in the drafting of legislative amendments, because as the medical practitioners or as healthcare professionals, we don't know the language of the law like that. But then that's when these folks came in and really, really made a big difference. There was a lot of advocacy with media and advocacy with members of parliament, where letters from patients and survivors and caregivers kept writing letters to their members of parliament saying, how can you let this happen? This needs to change. So it was really a multi-pronged approach that brought together lawyers, physicians, healthcare providers, and civil society advocates and people with lived experience. So it was a very, very concerted effort, but this effort took 19 years. And this is just some examples of the kind of letters and legal stuff and media engagement that happened over the course of those 19 years. And finally, after 19 years, we achieved success. And the NDPS Act was finally amended in 2014. It was adopted by the Parliament in February 2014. The President assented to it in March 2014, and by the 1st of May, it came into force. I still have goosebumps when I think about that day, because the story behind how that also happened in Parliament is quite remarkable. And if you've seen the film Hippocratic, a part of that journey is documented in the film. And I remember getting that message saying, it is, it's happened, it's done. And I've been a caregiver for several people with cancer, including my mother. And she had, it had been 14 years since she had died, and she had never had access to pain relief. So this hit home very hard for me. And I remember on that day being extremely emotional about it. But that's how personal this amendment really is to every single patient who is in pain at the moment. Now, what does this success look like? And what does it mean for you as medical practitioners? First of all, very importantly, the NDPS with this amendment recognized, it broadened the scope, and it recognized that opioids are essential for promoting the medical and scientific use of narcotic drugs and psychotropic substances. A new category of essential narcotic drugs was created, which the central government could notify. And all the rulemaking power for these essential narcotic drugs was transferred to the central government. And all that hodgepodge that was going on with different states was done away with, and all the rulemaking powers went to the center. So there were uniform rules that came out across the country. So these were the three broad strokes. What are these essential narcotic drugs? They're basically a set of drugs carved out of the category of narcotic and manufactured drugs. The word essential is important because it conveys meaning and purpose, that it has a meaning, it has a purpose. The central government can notify drugs as an essential narcotic drug without having to change the act or the rules of the NDPS. And it recognizes that the opinion of the medical community is important. So multi-stakeholder meetings are important. The doctors have to be consulted, physicians have to be consulted. I will not comment on how effectively we have been able to make that happen. And these essential narcotic drugs will be subject to uniform central rules throughout the country. But while making all of this accessible, it is very important to remember that penalties for illicit use remain unchanged, and those are harsh punitive measures. Yeah, so this is where we're trying to achieve that balance, make it more accessible, but ensuring that, yes, if there is illicit use, then those penalties still apply. Now, what are these essential drugs? Essential narcotic drugs, as per the notification, morphine and all preparations containing more than 0.2% of morphine, fentanyl, and methadone, which is also used in pain relief, as well as substitution therapy, hydrocodone, oxycodone, dihydroxycodone, and codeine. I've put these separate because firstly, the ones in blue are not available in India. And codeine is not really it's not a step 3 analgesic. So it's it doesn't fall into the same class of drugs or the same schedule as morphine, fentanyl, and methadone. So anyway, for the purpose of palliative care, the top 3 are absolutely essential, and these are the ones that are in the essential narcotic drugs list of India. Now, very quickly, to compare, what was the old procedure? Multiple licenses were required. Today, you need only a recognized medical institution certificate. Earlier, multiple agencies was involved. Today, it's only a single agency, and that is the state drug controller. Earlier, the validity period of each of those licenses, you needed like 5 licenses that were valid at the same time, for possession, for transport, for export, for all of those things. And they all had a validity period of like a year or something. So it made it impossible to have all the licenses in place at the same time. Now you can get the RMI certificate, and it gives you, space for, it gives you a license for 3 years, and it can be renewed after that. And earlier there were different procedures in different states. Today it's uniform across all states. So this is the NDPS at a glance, the amendments at a glance. Of course, the legal framework that the advocacy was done through was to ensure that we covered availability, procurement, stocking, and dispensing. We had to make sure that all these different areas featured for access to medicines in the legal framework that we were going with. And who can possess essential narcotic drugs? This is important for us to know. The patient can possess it for their own use, as per the quantities sold or dispensed at one time. It's that's an important part. A registered medical practitioner, and within quantity limits for use in his or her practice, which excludes sale or distribution. And morphine up to 500 mg, direct administration to patient under the registered medical practitioner's care. And exceeding quantity limits can happen with the authorization of the state drug controller. Any person authorized by the state drug controller or by a general order can also possess ENDs. A recognized medical institution can possess ENDs, and a licensed dealer or a chemist. So these are the categories of people who are allowed to possess ENDs with certain stipulations and considerations. And also educational or scientific institutes authorized by the state drug controller, the pilot or captain of an aircraft or ship for an emergency use under a specified order, and a person in charge of an ambulance for emergency use. So these are also people who, these are also groups of people who can possess ENDs. Who can buy it? From the drug manufacturer, licensed chemists or dealers, registered medical practitioners, persons authorized by the drug controller, and recognized medical institutions. These are the folks who can buy ENDs from the drug manufacturer. Who can sell it to patients? Only licensed licensed dealers or chemists on a prescription, plus the drug controller's conditions, and recognized medical institutions. Now, as a how do you get this recognized medical institution certificate? Any medical institution can apply for recognition under form number 3F. Now, we have a whole docket in Pallium India that has all these forms in the order that they need to be used. So please don't worry too much about this slide. We can provide you with that entire docket so you can have a look at it. This is just something that can guide you later to look at which form is used for what. And once you apply for it, it has to be granted within 60 days of the application. And its validity is for 3 years, like I said, after which it's up for renewal. And your recognition can be suspended or canceled or both. And both of that is appeal. I mean, and you can appeal that in a court of law. And government hospitals with at least one trained registered medical practitioner don't need to apply for recognition. They are deemed recognized medical institutions. So any government hospital with a trained RMP is a deemed institution. They do not need to go through this process of application. And but at the same time, it doesn't mean that those provisions for record keeping and documentation are different. They are the same, whether you're a government institution or a private institution or an NGO. And recognized medical, that's institution, not institute, where it has to have a medical practitioner who is the person in charge. And again, there are certain quantity limits as per estimates. Now, based on what you are, your estimated use, and then you can submit that. You have to maintain a daily record of stock, and patients have to be registered with the institution in order to be able to get that prescription. Your annual returns have to be filed under Form 31, and your records of all of these things have to be preserved for 2 years. You have to maintain these records for 2 years. And the state drug controller or an officer authorized by him can come to inspect the RMI. And you have to dispose expired drugs in the presence of an officer. So those are some of the conditions that apply. And home care treatment is permitted, but again, the patient must be registered with the RMI, with the recognized medical institution, and a designated medical practitioner in charge has to nominate a qualified person to carry that END, whether it's morphine or fentanyl, in the quantity needed for a patient. So if the patient cannot come, then you can nominate a qualified person to carry it to that person. And the END can be given to the patient at home or wherever they're residing, if it's in a care facility or in their own home. And the designated medical practitioner has to maintain records of used and unused drugs in home care. Now, it's a tricky thing, but this is something that is part of the provision of these amendments, of the rules that have been amended. And other important provisions for us to know is that there is no restriction or special requirement for interstate export or import of ENDs anymore. You don't have to worry about that. And you can procure through a consignment note. And this is not required when the END sale is with an invoice, and it's not needed for registered medical practitioners or recognized medical institutions. Ideally, unused ENDs have to be returned to the RMI, and who will treat it as a receipt. Again, we can have many conversations about that and about the how efficient or how realistic that is, and what are the challenges that come with it. And the thing is that ENDs cannot be transferred, loaned, or sold to other individuals without to other institutions, without prior approval of the state drug controller. So as an RMI, I cannot transfer, loan, or sell it to another institution unless the state drug controller explicitly approves it. Now, how do you prescribe it? The RMP is basically the person who can prescribe it, and it has to be in writing with a date and signature. And the full name, address, and registration number of the medical practitioner has to be entered. The name and address of the patient has to be entered, and the daily dose, what is the daily dose and what is the period of consumption has to be entered. These are absolutely vital details that go into the prescription. I don't mean to scare you with this slide, but so I've told you now about what the legalities are, what the amendments are, and how that applies in your practice. Very quickly, this is a snapshot. I want to let you know that this is dated information. This information the statistics you're seeing on this slide have changed. There has been improvement, largely due to civil society advocacy and all of that. But as of June 2019 and March 2020, the Lawyers Collective had basically gathered data through the Right to Information Act. And it found that out of 34 states and union territories, only 15 states had issued RMI certificates under the new NDPS rules. And in these 15 states, a total of 517 medical institutions had been granted RMI certificates. And but there were considerable variations from state to state. For example, Delhi had issued 184 RMI certificates as the state reported at the time, whereas big states like Maharashtra at the time of this RTI had only issued 4 RMI certificates. That has also changed. 2 states at the time, Himachal and Uttarakhand, had actually rejected all the applications that had come in. Goa and Meghalaya had issued licenses under the old NDPS state rules, even though those are overridden by the amendments. And we found that Jharkhand and the Andaman and Nicobar had reported that they had not received any applications at all. 13 states did not reply to the RTI, and that includes Kerala. So we acknowledge that we're missing a huge chunk of information, but this is just to share with you a little snapshot of how, in spite of the NDPS Act being amended, the implementation has been slow, it has been staggered, it has been inadequate right across the country. So what can you do now? All institutions providing palliative care and pain relief should ensure a doctor with training in palliative care. And like Katherine said, this is why all of you are here. This is wonderful. And once that person has been identified and trained and is in the institution, please place a purchase order for morphine and fentanyl or methadone with the manufacturer. Ensure proper I mean, of course, you then apply for the RMI, then you place a purchase order. Ensure documentation and monitoring. It is absolutely essential because that is the only way we can continue to prove that safe use of opioids is possible. And please know that the excise department is not involved in the process, no matter what is said to you. So that has been clarified. In fact, we've had to intervene as a WHO collaborating center in one of the states for precisely this problem where the excise was getting involved, and we had to actually say that no, as per the new amendments, the excise cannot be involved. And for more information, we're happy to provide that for you. But most of the information that you need will be in that docket, which we can share with you. And I just want to close by coming back full circle to the principle of balance. And historically, and even now, we always look at it from the perspective of control and access. And what does this come down to? It comes down to these values of something being harmful and something being valuable for care. And so all of the stuff coming from the control part is restrictive, whereas the things that we're pushing for are enabling policies. And all this while, we've thought that the two are two sides of a coin. We have no convergence. But there is a convergence. There is a place where these two meet. And that is in a patient-centric approach. Where is the true balance? Where does balance lie? Balance lies not in thinking of it as one against the other, but what is good for the patient. And that is our guiding principle towards what balance really means. And in order to achieve this, we have to focus on the suffering of the individual and the families. That is our priority. We have to focus on safe access to high quality data on opioid use outcomes, which is why I'm stressing on documentation, on monitoring in each of your institutions. And finally, we have to focus on partnership between government, professionals, and civil society. None of us can do this alone. And the amendments to the NDPS Act is living proof that it takes not just a village, it takes the whole country to get these changes going. And all the models of success that we're seeing today, whether it's in Kerala, there's an incredible model coming up in Telangana, where all 33 states, all 33 districts have access to IP, OP, and home care services. All of these successful models in India have come through partnership between government, professionals, and civil society. And we all have to carry each other, and we all have to, stay in that big tent. So I know by now you've all seen these pictures, but we've talked so much about, the law and data and statistics and the philosophy of advocacy, but it all comes down to this. This is it, that this gentleman was lying for 3 weeks in this position in so much pain that he couldn't even sit upright. And 3 rupees worth of medicine, he was able to sit up and have a cup of tea. This is what we're talking about. This is the access we need. So I'm going to stop with that. And we'll go back to a larger discussion now. I think Katherine and I, we're on time, Katherine, and Dr. Raj is here with us. So we'd really like to dedicate the next 20 minutes to unpack all of this information. If you have questions, how does all of this impact you as a doctor in India? So if you have any questions for us, the three of us are here. Dr. Raj.
I'm here, Smriti, ready.
So can we just throw the floor open? And I would actually also request, if you're not feeling too uncomfortable about it, if you can turn on your cameras. I know Katherine and I might be new to you, but I know you all know each other. So it's a Saturday evening. I hope you're relaxing at home while you're listening to us. So don't worry about where you are. Just, it enables us to engage with you better if the cameras are on. And please just unmute and step right into the conversation.
The registered medical practitioner can procure only 500 mg of morphine. Is that enough?
Shall I take the questions, Nuri?
Please, Dr. Raj.
Dr. Tendril, I mean, personally, I would recommend that you go through the recognized medical institution process. The provision for RMI, for the RMP, the practitioner, is only for you to hold something in your bag if you are doing a visit to a patient. 500 milligrams will not be enough for any significant use for more than a patient in a couple of days. So the drug controllers are also not generally very keen on giving this RMP quota because it's difficult to keep track of. My strong recommendation is that because it's ineffective, because all the drug controller may not give it anyway, you should go for an institutional approval as an RMI, not get a quota under RMP or registered medical practitioner in an individual capacity.
Thank you, sir.
Dr. Raj, there's one more question. Should the license be with the institution or the doctor?
Dr. Kale, I hope you heard my response to the to Dr. Tendrel's question. You can, I mean, it is no longer called a license, actually. It is approval to hold it, approval as an RMI, that's all. So the registered medical practitioner, as I explained to Dr. Tendrel, can get that approval to hold a small quantity with yourself. But that will not be enough for palliative care for more than a patient over a few days. So you apply for recognized medical institution status. It will be given to the institution. The doctor's name will be mentioned in it. That doctor will be in charge of that recognized medical institution. So if Dr. Kale, your institution is applying, you will need to submit a couple of forms. One will have to be signed by the head of the institution, naming you as an recognized medical, as the doctor in charge of that RMI. And that's what you submit to the drugs controller of the state. Dr. Kale, am I clear to you?
So thank you. Yes. Good evening, sir.
Good evening, Dr. Kale.
Sir, again, my concern is palliative care is mostly run by a lot of NGOs. Then how do they be able to supply morphine to the patients? I don't think the medical institutions will be able are willing to give free of cost, not everybody, but for the government institution and other few places.
Dr. Tendrel, so grateful to both of you for asking these questions. Many people would have the same doubt. So we are an NGO, Dr. Tendrel. Palliative India is an NGO. Our institution is an NGO. We apply. It's okay. NGOs can get it. Even if you do not have an outpatient service, even if you do not have an inpatient service, if you are doing only home visits, you can still be an RMI. The only condition is you should your institution should have at least one room which is safe to be locked and for the medicine to be kept. A double locking system is mentioned. For us, it is one lock on the cupboard and one lock for the room.
Thank you so much, sir.
Glad you asked.
Sir, good evening. I have a question.
Yes, Dr. Meenakshi.
Yes, sir. In pallium, what is the minimum or rather maximum duration for which you would give a prescription for morphine? What I mean is, if a patient is coming from far away, would you give 10 milligram Q4 Tawadi kind of prescription for a month, 15 days, 2 months? So, because in our institution, we are having this problem. Patients come every month for a refill. Some of them insist on getting a refill for 2 months because they live far away, or their follow-up date with the oncologist is given once every 2 months. So always this, I have to spend so much money to come and just get the morphine. So I sometimes we don't know what to do.
Dr. Meenakshi, the rules, this government rules do not specify the quantity or the duration, but we make sure that what we do is safe. Smriti, during her talk, highlighted the need for safe use. We do not want to send out such huge quantities which somebody may get tempted to divert to illicit use, and we have to be careful. Our routine practice, I'll tell you, we give it for 2 weeks at a time, ordinarily, not more than that, unless the patient is coming from far away. The patient is coming from far away, we give it for a month, not more than that. That is not according to the rule, it's the limit that we have set ourselves. So what happens when a patient comes from another state? So initial prescription is given by us. Thereafter, our follow-up may be virtual. And we'll allow any family member, and usually it happens, a volunteer representing the patient comes with the official details and information, and we give it to them. There is a provision also for sending it by registered post. Only thing is, you have to, in that case, we have to make sure that the request is genuine, that the patient is alive. It's very, very unusual for somebody to fake it, but unusual things might happen. So we will connect with one doctor directly in that city, make sure that the patient is seen by that doctor, and then we may send it by registered post. The only catch is by the conditions laid by the National Medical Commission, we cannot prescribe based on virtual consultation for control medicines. That's a limitation. So, Dr.
Thank you
Meenakshi,
so much.
if you do not have morphine, I'm just hypothesizing you have it, which is great. If you did not have morphine, you have a patient who needs morphine and you cannot get it in your state. What we will do is to work with you, make you an honorary consultant for Pallium India. You will have to prescribe, and then we'll send it. This, I mean, like, we have to be accountable. You have to be accountable.
Thank you, sir. So I have one more question. Is it
Yes,
allowed?
doctor.
Sir, some of the patients, for example, we give them morphine for a month, and it so happens that they pass on. How do I ensure that the family brings the morphine back to me? Because some of them do, they're very sincere, they appreciate its worth, but some of them are not bringing it back. So we are really in a corner. I mean, they have signed documents saying that they will do it and all that, but once a patient passes on, they say that, we've just thrown the morphine or some such thing like that. So do you have this problem at Pallium India as well?
I'm not sure that that's a problem, Dr. Meenakshi, not a big problem. The rules specify that you can receive return medicines. The rules do not say that it's anybody's responsibility to return the medicines to you. And it is common practice, Katherine, this may come as a bit of a surprise to you. When people are cremated, very often all the medicines are thrown into the funeral pyre. And we cannot retrieve it. So, Dr. Meenakshi, you do not have a responsibility to get the medicine back. If they bring it back, should encourage it. If they bring it back, you will enter it in stock. If they destroy it or throw it away, there's hardly anything you can do about it.
Thank you, sir.
There are other questions on the chat box. Dr. Molly, would you like to ask the question or?
No, sir, I was just stating the fact that we have progressed much from what Smriti was telling about Uttarakhand status to institutions. Now our hospital is an RMI now. So we thank you so much for championing the cause and changing the situation in different states. Thank you so much.
Dr. Molly. Raju, can you stop the recording for just a minute?
Yes.
I want. So my response to everybody is, when you have issues about this kind of thing, one, for the technical expertise, please come back to us, because we have these years of experience of various problems in various states, and we can help you. Secondly, whenever you are putting in applications or anything to the drugs controller, please write it in, send it by registered post. Keep a file separately for that. You will need the evidence. When we approach the authorities later, say for example, in Uttarakhand, we approached as a WHO collaborating center, and the drug controller was very receptive. So do please write and register, keep it documented properly. If you just go and talk to them, that's not enough. Dr. Sheila?
Yeah, yes, sir. Good evening, sir.
Dr. Sheila, your private practice will have to be an institution.
Okay.
If you just put up a personal signboard outside your home and apply for RMI status, you will not get it. It is a recognized medical institution. If you call it Dr. Sheila Rathod Clinic,
Okay.
and depending on the state, you will have to do the appropriate registration if there is a registration that's needed for medical institutions. For example, in Kerala, we have to get registered with the local self-government, which may be a panchayat or a corporation. In Delhi, every institution has to be registered with the Director of Nursing Homes. So each state may have its own rules for registration. So that process will have to be gone through. It is, if you apply only as an individual, Dr. Sheila, you will get only that RMP thing, which will be only 500 milligrams, which will not serve your purpose.
Then how do I go about it, sir?
Then you will have to register it. I mean, you will have to call it an institution. And depending on the Dr. Sheila, which state are you in?
Sir, Mumbai, sir.
Mumbai. I am sorry, I do not know the rules there. We can find out. So if you are registering as an institution, it
Okay,
may
sir.
be with a corporation, it may be with another body of the government, that, or it may be with the state government itself. That registration may be necessary. So you will have to make yourself an institution and not just a person.
Okay.
Only one doctor is enough. That is not a problem.
So I have my clinic. I mean, my clinic is registered, so it's in the name of my.
Okay, that's enough. What's it called?
It's called Bhavi Clinic. It's on my daughter's name, sir, and my clinic is a registered clinic.
Okay, so that is the clinic. I did not quite get the name of your daughter, Bhavi something.
Bhavi, yeah, sir.
Okay, so Bhavi Clinic applies for the status of recognized medical institution.
Okay, okay, I can do that, right?
Yes, yes.
Right. Thank you, sir.
As part of the material that we give back to participants, we're happy to share with you the entire, there's a flow chart of each step, the forms that go with each step. So we'll be happy to share that entire docket with each of you. So if you have any, and if at any point you get stuck, we're happy to assist with that as well. Dr. Raj?
Yeah. I mean, I was Dr. Kale. If there are problems, we would consider a privilege to work with you. But let me also tell you, in some states, can be a very tough challenge. For example, Punjab, where addiction is there, is higher than in other states. It's a border state. It's a lot of sensitivity about drug trafficking. Very difficult to handle the problem there. Officials may not be very willing to listen. So one lesson that this has all taught us is we have to be persistent, not give up, not pick up fights, but continue to nag the powers. And nagging is a very effective thing if you don't mind getting a little shouted at times. I don't mind. People can be rude. That's okay.
right.
We have a noble mission to do.
Yes, yes.
An occasional insult is okay.
Right.
Catherine, you wanted to ask something?
Yeah, I had a question for you and or Dr. Raj. And first of all, congratulations on the incredible work you've done. It's really impressive. So my question goes back to, do you think that the new system under the NDPS Act revisions and what you're talking about now for each and every doctor who's attending and how they can get this done, do you think that it's a balanced system now? And if it's not, what would make it a balanced system?
Smriti, you want to go ahead or shall I?
Please go ahead, Dr. Raj.
Catherine, I wouldn't by any means say that the current system is very good. It's not. It's better than before. There are more than one problems. The rules contain several issues which we have been asking for revision for 5 years now. There are obstacles which we have not been able to tackle, but they are okay. They are minor problems. There are still problems, Catherine. The harsh penalties are still on. Fortunately, they don't seem to affect us much, but we have represented to the government that there should be a distinction between licit use and illicit use. If there is a clerical error during licit use, that should not be considered just like a drug trafficking. This is one of the amendments that we have requested. So, Catherine, sometime back during one of our discussions, you were looking for a good process. India doesn't have that good process to as a model yet. But we can, I suppose, work together to create an ideal thing that we would like to have, but what we have now is not ideal.
Thanks. Would you think that part of having a good process would be having more drug treatment centers? Is that necessary in India? It certainly is in the US. It's very hard to get drug treatment in the public center. So, you've got all these overdoses in this whole North American opioid crisis, but they don't have a balanced system because they don't have access to treatment.
The system here is, Catherine, sorry to say this, very, very, very bad. Addiction is generally not considered a disease, which it should be. It is considered a crime, almost invariably. People are treated very badly. See, dear friends, all the participants, I don't know whether you have ever thought about it that line. The person who has addiction is somebody who is suffering intensely. It's intense suffering for that person and for the family. They also deserve our empathy. They also need treatment. I mean, what is being done is absolute cruelty. And yes, Catherine, I must also confess that we have not really meaningfully entered that area. The addiction medicine people are scarce, hardly any, and people who should be caring for them do not seem to care such a lot. So that's a sad situation.
So it's still seen, like I was saying in my lecture, as an evil, just
Yes.
like in the single. That needle hasn't moved at all.
Not at all.
And I think that level of social change is also required, because that is the very tool by which the control part is constantly pushed. And for those of us who are in palliative care, I think we need to see, what we were talking about, the balances in the patient-centeredness of it. But going by what Gabor Mate says, he says if mental health is the poor sister of the health system, then addiction is the second cousin who lives in the slums. So a lot of the, even our compassion apparently has limits. And I think we need to get past that, because if we're looking for law reform for access to controlled medicine, we cannot ignore the other side. So, yeah.
So,
do I have just a second to say something? I don't want to keep people.
Please.
no, of course you must.
Yeah, the penny really dropped for me, to use an English metaphor, but I was in Sarajevo, actually, in Bosnia, after the war, and I was really supposed to be on vacation, but I can't help myself sometimes. So I was investigating the state of access to medicines and palliative care in Sarajevo. And they said that they had some access to morphine, which had been brought. I mean, this is a theoretically modern European city, even though it's in Southern Europe. And they said, well, yes, we've had some access to morphine. And she said, we can treat our cancer patients in the city. And this woman was saying, well, we did have a patient who got dependent on morphine, a breast cancer patient. But, once we realized that was the problem, we sent her to a recovery program. And then it was fine. And it was like, well, duh, if you have a patient who becomes dependent, because that's what everybody's worried about, oh, I'm going to get addicted. But, if you have those services available, then it's not an issue. So she wasn't worried about it because those services existed. And that's, to me, where the balance is too. If you have exactly that patient-centered approach without judgment, that if they're an evil person, you just send them to a treatment center.
Catherine, yes, and I want your attention and Smriti's attention to this for the future. So we have in the past, when during our advocacy, talked quite a lot about this, like whether we should be advocating for both rather than just for access to opioids for pain relief. And the decision that we took at that point of time was, it will be spreading ourselves too thin. We will be encroaching into an area where we do not have a lot of expertise. And we'll be shifting the focus of advocacy from one problem to two problems. So we decided not to. I feel guilty about that some way. That's not fair. We being concentrating only on one. But then also I thought maybe the ideal thing would be to get a good collaboration with an addiction medicine department and strategize in two arms, concurrently asking for both in collaboration, just as we are trying to get that Lancet Commission triad in. Maybe that's the answer, but maybe not possible now. I know we don't have the time, but at some point, the three of us should be discussing that more with the participation of anybody else in the group. I think that's a discussion that's badly needed. Dr. Murali Krishna, absolutely yes. Dental clinics can be registered as RMIs. Yes.
I think we have time we've overshot, but Meenakshi, if you'd like to ask your question, please go ahead.
Okay, I'm very sorry to keep you all. I have a patient, sir. She's a patient who had a cancer of the uterine cervix. She's been treated with the chemotherapy radiation. And right now, she's cancer free. I mean, she's been in the cancer free zone since the last 2 years. At some point during her disease trajectory, she was started on morphine, and now it has been de-escalated systematically. But even now, she complains of a low backache radiating down her legs, and she comes back every month for morphine. She takes one tablet of morphine, 10 milligrams, 3 times a day, and do what I mean, whatever we do, she's not willing to let go of the morphine. Frankly, we don't know what else we should do for her. We've tried physiotherapy, we've tried orthopedics, but no, she simply wouldn't. She doesn't comply. She just comes back for the morphine. She says, "I can't sleep if I don't have that drug. I'm in pain throughout the day. At least this helps me go to work." So, what should our approach be? I mean, is this person addicted to morphine, or has she got I mean, she may have chronic pain, but is morphine the answer there? So I don't know what to do with this patient.
Dr. Meenakshi, maybe at some point of time we should talk more about this and plan properly. That woman is again suffering. You are also suffering because you are in a dilemma. I think we'll have a consultation about it, Dr. Meenakshi, indeed. But for everybody, just to get a brief idea, one, this woman might have got dependence. Yes, that's a possibility. On the other hand, she is complaining of a very specific pain. Pain radiating down the leg is fairly typical of a nerve root compression pain. Maybe she has an unrelieved disc disease and she is in severe pain and she needs this. In which case, maybe we should systematically try other modalities of treatment. She should have the evaluation by a neurologist or orthopedic surgeon with a view to be doing a micro discectomy if necessary, followed by gradual withdrawal of the morphine. So this is this is not common. This situation occurs rarely, and we will have to handle it as a medical issue. Dr. Meenakshi, we'll discuss that. Please keep in touch with us.
Thank you, sir.
Katherine, Dr. Molly Thomas has written a paragraph complimenting you and thanking you. And I think all of us will join together. It is not easy to conceive of one human being making such an enormous difference on a global scale, purely by her analytical mind, systematically analyzing the problem and being systematic about advocacy. So, Katherine, all of us are grateful to you for what you do internationally. Thank you.
It's mutual. I mean, we all reinforce each other and inspire each other. I couldn't do what I do without what you do. It's an ecosystem. But I'm a nag. There's absolutely no question that I'm a nag at the international level. It's a title I take proudly.
It is, thank you, Katherine. Thank you for your nagging. It is 5 minutes past the time. I know Raju gets violently mad if we exceed time too much. But there is a question from who is that? From Dr. Punita. I don't know if Raju will allow us to take that question also. I'll risk it and go ahead. How common is morphine dependence in the Indian setup? Should we be worried to prescribe? Dr. Punita, if we have given somebody morphine or another opioid for long enough time, the person would have, most likely would have physical dependence. And that means if you stop it all of a sudden, the person will have horrible withdrawal symptoms. So if somebody who never consented to radiotherapy finally consents to radiotherapy, and then the pain is gone, you will have to gradually withdraw it 1/3 at a time or taking several weeks or sometimes months over it. That's the first part. Secondly, addiction is not exactly that physical dependence. Addiction is something that occurs with usually manifesting as increasing dose, unsanctioned dose escalations, and somebody who has gone into addiction is unlikely to be satisfied with the same dose over a long period of time. It'll keep on increasing the demand. So those are two different things. But the important take-home point there is, if somebody has had a opioid for more than 3 weeks, better withdraw it gradually. If somebody has had it for months or years, withdraw very gradually, not abruptly. Raju, that was